Hello and welcome. Today we're delving into a fascinating and potentially vision-threatening complication following a vitrectomy post-vitrectomy elevated intraocular pressure, or IOP. So, what causes this rise in eye pressure after vitrectomy surgery? The etiology is multifactorial, meaning it involves a combination of factors. One major culprit is the use of intraocular gases or silicone oil to tamponade the retina. These substances can obstruct the trabecular meshwork, the eye's drainage system, leading to pressure buildup. Other causes include inflammation following the surgery, changes in the lens position or angle, and pre-existing glaucoma that's exacerbated by the vitrectomy. Steroid use post-surgery, used to manage inflammation, can also contribute to elevated IOP in susceptible individuals. Finally, retained lens fragments after cataract surgery combined with vitrectomy can block aqueous outflow. Let's break down the pathophysiology. Normally, aqueous humor, the clear fluid in the eye, flows from the ciliary body through the pupil and out through the trabecular meshwork. When gas or silicone oil fills the eye, it can physically block this outflow. Inflammation, often triggered by the surgery itself, can further compromise the trabecular meshwork. This blockage increases resistance to aqueous outflow, causing the pressure inside the eye to rise. In cases of steroid-induced glaucoma, steroids alter the gene expression in the trabecular meshwork cells, decreasing aqueous outflow. If the IOP rises too high, it can damage the optic nerve, the crucial pathway for visual information to reach the brain. This damage is the hallmark of glaucoma. Determining the exact epidemiology of post-vitrectomy elevated IOP is challenging, as it varies depending on factors like the type of vitrectomy, the indication for surgery, and the patient's pre-existing ocular conditions. Studies suggest that a significant percentage of patients, ranging from 10% to as high as 60%, can experience elevated IOP in the weeks, months, or even years following vitrectomy. The use of silicone oil tamponade is associated with a higher incidence compared to gas tamponade. People with pre-existing glaucoma, diabetes, or those requiring multiple surgeries are also at increased risk. The signs and symptoms of post-vitrectomy elevated IOP can range from subtle to severe. Many patients initially experience no noticeable symptoms, especially if the pressure increase is gradual. However, as the pressure rises, they may experience eye pain or discomfort, a feeling of pressure or fullness in the eye, blurred vision, halo surround lights, or even nausea and vomiting in acute cases of very high pressure. Sometimes, the first sign is progressive vision loss discovered during a routine eye exam. Therefore, regular monitoring after vitrectomy is crucial. Diagnosing post-vitrectomy elevated IOP involves a comprehensive eye examination. The most important test is tonometry, which measures the intraocular pressure. Gonioscopy is also essential to examine the angle where the iris meets the cornea, to see if the trabecular meshwork is blocked by gas, silicone oil, or other debris. Visual field testing helps to identify any peripheral vision loss, a common sign of glaucoma. Optical coherence tomography, or OCT, is used to image the optic nerve and retinal nerve fiber layer, looking for signs of glaucomatous damage. A careful review of the patient's surgical history, medications, and pre-existing ocular conditions is also critical. While we don't have distinct types of post-vitrectomy elevated IOP in the traditional sense, we can classify it based on the underlying cause. For example, we might refer to gas-induced IOP elevation, silicone oil-induced IOP elevation, or steroid-induced glaucoma following vitrectomy. Another classification is based on the duration: acute, which is sudden onset, and chronic, which develops over a longer period. Understanding the underlying cause helps guide the treatment strategy. The treatment and management of post-vitrectomy elevated IOP depends on the severity and the underlying cause. Initially, topical eye drops that lower IOP, such as prostaglandin analogs, beta blockers, or alpha agonists, are often prescribed. If these are insufficient, oral medications like carbonic anhydrase inhibitors may be added. For gas or silicone oil-related IOP elevation, repositioning the patient may help to relieve the obstruction. In severe cases, laser procedures like selective laser trabeculoplasty, or if that doesn't work, incisional surgery such as trabeculectomy or tube shunt implantation may be necessary to create a new outflow pathway for the aqueous humor. If steroid-induced glaucoma is suspected, tapering or discontinuing the steroid is crucial. Preventing post-vitrectomy elevated IOP starts during the surgical planning phase. Surgeons should carefully consider the choice of tamponade, minimizing the use of silicone oil when possible. Using shorter, acting gases helps prevent prolonged obstruction of the trabecular meshwork. Meticulous surgical technique to minimize inflammation is crucial. Post-operatively, close monitoring of IOP is essential, especially during the first few weeks after surgery. Prophylactic IOP, lowering medications may be considered in high-risk patients. Patient education about the potential risks and symptoms is also vital, ensuring they promptly report any concerns. The prognosis for post-vitrectomy elevated IOP varies depending on the severity and duration of the pressure elevation, as well as the effectiveness of treatment. Early detection and prompt treatment can often prevent significant vision loss. However, if the pressure remains elevated for a prolonged period, irreversible damage to the optic nerve can occur, leading to permanent vision loss and glaucoma. Recent research is focusing on developing new biocompatible tamponade agents that minimize the risk of IOP elevation. Novel drug delivery systems are also being investigated to provide sustained release of IOP-lowering medications, reducing the need for frequent eye drops. Finally, studies are exploring the potential role of minimally invasive glaucoma surgery, or MIGS, in managing IOP following vitrectomy. Thank you for joining us today.